the Pediatric Lounge, a podcast taking you behind the door of the physician's lounge to get a deeper insight into just what docs are talking about today. From the clinically profound to the wonderfully routine and everything in between.
This episode is sponsored by our friends over at Hippo Education. Quick question. When was the last time you felt you were fully up to speed on the non-stop updates in pediatrics? Let me guess. Never. That's where Hippo Education's Pediatrics Reviews and Perspectives podcast comes in. Your monthly pediatric cheat code. Fresh, up-to-date insights from pediatric clinicians who live and breathe the same challenges you do. No fluff, no boring lectures, just practical knowledge you can apply on your next shift. The best part, you can listen and earn CME whenever it works for you on your commute between patients or during that rare quiet moment. So, if you're ready to make staying informed easier, check the link in the description or visit hippoeducation.com to try Hippo Education today.
Good morning, George. It's Tuesday and we get to tape another podcast. Today we have a great guest, a man from Boston in Pennsylvania, Dr. Christopher Russo.
Yes, today's topic of discussion is about a pediatric hospital's journey from Boston, leading a large community system in Pennsylvania.
So Dr. Russo is a pediatrician who specializes in pediatric hospital medicine. He is the director of Pediatric and the medical director of quality and innovation at WellSpan Health System in York, Pennsylvania. He's also an assistant professor of the Department of Pediatrics at Drexel University College of Medicine. Welcome, Dr. Russo. It's a pleasure to have you on the podcast.
Thank you. It's a pleasure to be here.
We always start by asking people, why did you become a pediatrician?
Sure. It's interesting. My parents are both public school teachers in Boston. So I didn't grow up from a physician family, so I knew very little about medicine. I was never sick. I never needed hospitalization or anything like that, thankfully. But I think medicine had a calling for me that I always thought maybe living in Boston, of course, where you have Mass General Hospital and Boston Children's and all the wonderful institutions. It was a very medical community that I was familiar with. But it was really when I was in college that I was able to really decide that's where I wanted to go into medicine. I had the fortunate opportunity when during my spring break of sophomore year, I wasn't going away partying or anything like that during my spring break, but was able to do an internship for those 2 weeks with the chief of surgery at Massachusetts General Hospital. And it sounds silly now, but at that time, I had always thought medicine was very boring. I had thought, boy, you go to medical school, you learn how to do things, and that's what you do for the rest of your career. And boy, that seems entirely uninteresting to me. But then I got there and I saw people arguing about what was the best way to do things, talking about, I went to this conference and I learned this new technique, or I read this journal and this is how they're doing it over there. And the thought that I was going to be in a profession that was constantly striving, constantly trying to improve was very exciting for me. And that's when I decided that I want to go into medicine. Now, when you get to medical school, of course, you go through all of your rotations, and not having really a medical background, I liked everything I did. But pediatrics was by far the most difficult of all the rotations I had. I realized that it's not just the child, it's the parent, it's the caregiver, it's trying to understand in a 2-day-old what could potentially be wrong when the child can't tell you what's wrong with them. The 16-year-old who doesn't want to also tell you what's wrong with them. They just want to clam up. What do you do in that situation? Really, every time I knocked on that door and opened up the door, it was a new experience. A 12-year-old boy and a 12-year-old girl, they're not the same. All 10-year-old girls are not the same. There's the whole development. And that to me was so challenging. And I thought, this is where I want to be. This is exciting. And to really be a part of that's what sold me on pediatrics.
Wow. So you like to argue.
Yes. I like to teach, and I feel like in pediatrics, I do a lot of teaching. I think it's from my parents. I inherited that love of teaching, and I'm teaching the children about the disease that they have, teaching the parents and the caregivers about how to care for their child. I'm drawing all the time. It sometimes drives the nurses crazy. I'll draw on the sheets. I'll draw on the whiteboard in the room and things. I'll bring my own whiteboard sometimes. I really love to teach. I feel in pediatrics, I'm able to do that.
And when you were teaching at the medical school, does that still exist, that back and forth? Because the argument back in the day were brutal. I can't imagine at Mass General and with the chief of surgery, they were brutal. They went for the jugular and nobody wanted to lose.
Absolutely.
Is that back and forth still exists in medical school, or are they more like drones?
It's interesting. I think when we were going to medical school, there was great primacy on knowing the patient. That if I asked you and I said, Herb, tell me about this patient, tell me what medicines they're on, you would have to know what those medicines were. Maybe you could get away with an index card that had some of those things written down. And now I feel like there's a lot of reliance on electronic health records and saying, okay, let me look that up. I'll say, when's the last time the child had a fever? Let me look that up. Things that I think we just assumed, boy, you had to know that. If you really knew your patient well, you'd be able to handle all of those questions. So I think it is a little bit different. And certainly I am appreciative of the resources that the students and the residents that I teach have available to them. I do think there's just come a little bit of a loss of getting to know your patient because it becomes a crutch in some ways.
You think that's good or is that bad? The looking up part of it.
Yeah, I do think it's bad. It's funny. I will usually give like an introduction talk to our residents, and I'll say sometimes to residents, so tell me about the child in 401. How are they doing? Maybe we saw them in the morning rounding, and now it's the afternoon. And they'll go to the computer to look at their vitals. I'll say, well, sure, the vitals are important, but how's he doing? Have you gone back in and re-examined him? Have you talked to the parent, talked to the caregiver, asked how their child is doing? And I really emphasize that it's multiple, in the hospital in particular, it's multiple observations that you need to have. So I do think that over-reliance, George, can be a bad thing.
The standard answer I get often is, I haven't seen that patient yet. I got on right now.
Yeah, I haven't seen. I can tell you what's in the chart, but I haven't actually seen the patient.
Mm-hmm.
Yeah, I think it comes at a loss of getting to know the patient, but also getting to know that family. One of the things that I teach is that you need those multiple observations because children are just so resilient. That child who looks sick as stink in the morning is bouncing around and running around and ready to be discharged by evening time. And unless you've had those repeated observations and talked with the family and kind of coached them and say, boy, you just had an applesauce. Isn't that great? Okay, I'll come back in an hour or 2 hours and see him. And that, I think, really is a loss for our residents. Is really try to emphasize the importance of multiple observations.
And what else I'm also observing in the hospital is cases of that applesauce kid. Easy applesauce. So can we discharge him now? It's only been 12 hours. It's discharges that are being sent out real quick. I don't know. It's extraordinary. Why are we sending them out so quick? You usually knew how long an illness would take to get better, roundabout. Now he's jumping up and down and he's looking good. Let's go home.
Yeah. I think what I always stress with our residents, I say there's 2 questions I want you to be able to answer for me. Why did we admit this patient? And when can we send them home? And I say that because that really helps you form your differential diagnosis and helps you put in context what we're doing here, right? So I'll say, okay, so why did we admit this patient? Well, we admitted him because he's requiring supplemental oxygen. And when can we discharge him? When he's no longer requiring supplemental oxygen. So now let's try to think, why is he on supplemental oxygen? Is it he has pneumonia? Does he have asthma? What could it be? Bronchiolitis, depending on the age. Okay, now the child was requiring 2 liters and now requiring 4 liters. So my goal is to get you off of oxygen. Now I'm going the other direction. Why is that the case? Let me revisit my differential, right? My goal is that. And the other thing, I have a saying that I use, that I created. I said, if you admit for the wrong reasons, you won't be able to discharge for the right reasons. Meaning, I very early in my career, when I started as a pediatric hospitalist, I got a call from our emergency department and they said, I've got a child with a fever. They need to be admitted. And I laughed and I said, why don't I admit kids with fever? What do you mean you don't admit kids with fever? I said, well, you didn't tell me why he had a fever. That's your job to figure out why he has a fever. I said, if he's got a viral illness, he is going to have a fever for several days. Now, if you tell me he's got a fever and he's lethargic, he's got a fever and he's got abnormal labs, he's got a fever and he's dehydrated, things like that. The problem is if you admit, well, I'm admitting you because you have a fever. Okay, the next day, that kid also has a fever, likely a viral upper respiratory illness. And he's running around, tearing up the room. And boy, Mom, I think he can go home. He looks great. Mom, look, he's so active. He still has a fever. I'm not taking him home. Oh, but Mom, it's a viral illness. You admitted him because he had a fever. He still has a fever today. You haven't done anything for him. And so that's why I really emphasize that when I talk to parents, particularly, I say, okay, here is why we are admitting your child. Here are the goals of care. It could be fever, right? It could be your child's bacteremic, and I want to make sure they're fever-free before they can go home. It could be neonatal fever that you're looking at, a number of different things, but be very clear on why you are admitting. So then when they meet those discharge goals, they can go home. Absolutely, I agree, George. I think there is a pressure to send children home too early, particularly just going by one observation. Oh, he just made a wet diaper, so he can go home. That's his first wet diaper in 24 hours. I'd like to see a little bit more than that. So,
Yeah,
I answer the conversation, Herb, if you were the ER physician admitting that fever.
I didn't admit fevers. The conversation I have with parents now that I'm an Hospitalist is, they go, should I treat the fever? I'm like, sure, you're going to be disappointed. In 3 hours, Advil, ibuprofen, or Motrin, whatever you want to call it, the half-life's done. That fever spikes back up. And so you're going to feel like you're a failure, but do it. Or you can do it because the child feels miserable. So the kid has a headache or he's achy and he's not moving. He's in the couch because he's got influenza and every muscle hurts and every bone in his body hurts. His temperature may be normal. Give him some Motrin so he feels better. Because children, even adolescents, sometimes can't really tell you what it is that's bothering them. But you see him laying in the couch and that's not normal. He's just got no energy because everything hurts. And then the kid perks up. And so you know that you did good. And then the fever will run out. Call me back if it's there in 5 days. That's when I start working them up. Before that, 3 to 5 days is a viral illness. If you're fully immunized, there are very few things that are horrible about a fever today if you're fully immunized. I don't see non-immunized kids because I don't remember how to order an occult bacteremia workup anymore. And I don't. And I did plenty of them in the ER. And I don't want to live like that anymore. That's the dark ages. But
in the emergency room, the physicians in that emergency room are child pediatricians that admitted a fever.
oh man, there's all kinds of people out there. There's still pediatric hospitals with peds ERs that the child comes with a fever and they turn a fan in the exam bay and they take a rag with lukewarm water and sponge the baby down because the fever is harmful, because that's the way that hospital's been doing it for 50 years. It's like, why would you do that? It's unnecessary.
yeah.
That's what they did when I was at this pediatric emergency room. So now every time my kid has it, I do it.
Yeah.
Okay. Good luck. But I have a, this is a clinical question, Dr. Russo, because this shocked me. I have a friend, more than a friend, and the youngest baby this season, this is her second RSV season, got RSV, fever of 5 days, high fevers. Second or third visit to the pediatrician, of course, I am the TV pediatrician, right? They call me and my mother's a PA and she's, Herb, do you think this is normal? I'm like, 3 days is normal. 4 or 5 days? No. You need to go back to the pediatrician and see what's going on. RSV positive. They do a pulse ox, which I do on every patient with a fever or a cough. Just like you said, I admit because they're hypoxemic. If they're not hypoxemic, okay, everything is good. Come back tomorrow. We'll check again. And they went to the pulse ox in the office, 85%.
Oh, wow.
So either the thing is broken or the kid's really in trouble. And so the dad calls me. I actually called the dad to make sure he was okay because he isn't at work. He goes, Yeah, they just got to the ER doc said an hour or two they could send her home. I'm like, where are you? The pediatric hospital. I'm like, I know Denver. Are you in Aurora? No, this is in a nice neighborhood. The pediatric hospital said, oh, okay, a community hospital branded with Children's of Denver. I see. I said, the no PICU, the specialists are not there. He says, no, they're not PICU. I said, you know what? My experience is that when you're an asthmatic and your daughter's not asthmatic, but you came with a pulse ox less than 90%, I didn't even waste time. I put you on oxygen, started the net, started an IV, gave you some steroids, started writing orders to admit you. Those kids never turn around. It's a waste of time. You just tell the mother, this low of an oxygen doesn't turn around fast. There's a lot of inflammation. I don't know how many days it'll take for the inflammation to go away, but as long as you need oxygen, you need to be in the hospital.
Mhm.
So the mother calls me and says, the ER doctor wants to send me home with an oxygen tank. And this kid's not even a year old. I'm like, did you tell him F no? Absolutely not. Do you want me to call one of the big Pumas in Denver, one of the well-known pediatricians that's been around for ages that will just crush this little guy into little pieces? So no, I got it. They got admitted. They have to be transferred to the mothership. She ended up in the PICU with high flow oxygen. And I'm like, maybe I'm just out of touch. But the idea of sending a totally healthy young under an age, she's, I remember 11 months old, on oxygen when they're not a chronic patient, nobody's going to have the time to teach his parents. How are they going to monitor them? Why would you even suggest that? This is what hospitals are made for. You admit this patient. And I see by the shock in your face that you don't do that at your hospital either.
But I have heard that in places with higher elevations, that they have sometimes sent hospitalized patients home with oxygen. I've heard anecdotally that you might have a child who had bronchiolitis who came in on 2 liters and is now just at zero point 0.1 liters per minute and is just there for days and days. Otherwise, because of the altitude, sometimes they will say, and give the parents the option. Yeah, I do think there is an over reliance sometimes on vital signs in the sense of saying, "Oh, he improved with oxygen. Let's send him home." No, think about pathophysiologically what's going on here. Sounds like probably bronchiolitis. I don't know if there's a family history of reactive airway disease potentially, but the other thing that I think we have lost as with this generation, and I hate to make it sound like, oh, in our day, but I ask parents and the residents and what is the tempo of the illness, right? So if you tell me it's 5 days of fever, is it getting worse? Do you feel like your child is materially worse than they were the day before? Or do you feel like it's just he hasn't kicked it? It's just hung around. And then sometimes you're thinking, okay, was it really 5 days? Was it 2 days, then a day with no fever, and then maybe reinfected? I say that because the tempo is very important for me. When you think about a superimposed bacterial infection, which we'll see that starts out viral, but then for whatever reason, the child doesn't get better and then becomes a bacterial pneumonia, let's say, there's some worsening that you can point to. So in that situation, presumably that child wasn't hypoxemic for 5 days, but somewhere along the line, then became hypoxemic. So, okay, the tempo here is now things are worsening. And then we need to think about, okay, what is that intervention I'm going to do?
Yeah. Yeah. I thought that was so cavalier. A mother is exhausted. They have 2 kids. Kid's been sick for 5 days, hypoxemic. It's not a chronic disease. Some people can handle chronic disease at home. They've been admitted 10, 15 times. They know exactly what the routine is and they'd rather stay home. It's more comfortable. And okay, then we'll see how we can manage that for you. I was shocked. But anyhow, while I was looking up all the great things you've done, this really came to my mind. How does your faith inform your passion for the work that you do?
Yeah, I think for me, it's very important. I feel like it is the guiding principle that you use. It helps you understand, certainly in pediatrics, some of the hard things that we face. And so my faith has helped me cope with things like horrific child abuse. I trained in Philadelphia where we saw some really tough cases of child abuse. We had a burn unit there, and just those things can really wrench your soul. And so being able to have faith to rely on, to cry out when just and really have companionship. My wife as well has been very helpful with this. That has really helped me be a pediatrician, I feel, because then it helps me think about the child in the whole context of their life and their illness. It's very important to me. And I think about medicine and pediatrics as a calling. And I say that I didn't go into pediatrics. I didn't want to be a doctor, but this is where I felt called to be and led to be. And I think that's when you think about, is this a job or is it a vocation? So from the Latin vocare, to call, we think about it as pediatricians, we're advocates, right? An advocate from the Latin, to call towards, to bring and draw attention towards. Like for me, my faith has helped me realize that what I'm doing is a vocation. And then I do joke, I am a Christian, I'm Catholic, that Jesus says, unless you are like one of these little children, you can't enter the kingdom of heaven. And really emphasizing the importance of children and how a child thinks and how the child is just so free. And as I said, if that's what Jesus said, then I should study children. I should be a pediatrician. That's what he said to do. Be like a child and let me spend my time with a child for children.
So I love many things about what you just said. First of all, you put that out there on the internet, which I think is important for people to understand that physicians, we're human beings. We eat, hopefully we shower, we go to the bathroom like everybody else, and we have feelings, and sometimes we do feel lost, just like every other human being does. But often we don't talk about that. And I think that's to our detriment, because I think the number of suicides in our profession is incredibly sad. The number of burnouts, people burning out just because they see things that they can't unsee, they can't fix. And there's nothing but prayer to help you get through that, or a strong shot of bourbon, which is what I like to do. But it is true, though. It marks the end of the day for me. It's a ritual. And then the other thing that you said, which I really think has been lost, is physicians used to be like clergy. You dressed one way, you did one thing, you might have had the shot of bourbon at the end of the night because you were done with all this stuff, but someone calls, you put your clergy dress back on, you get on the car, you go to their home, and you sit with them. And I don't think that's there. It's a job. It's from this hour to this hour, and then I'm done. And that to me is the biggest loss I've seen in the last 30 plus years as a practicing physician. We are not a vocation anymore.
Yeah, I'd agree with that. I think one of I do a lot with WellSpan, and WellSpan as a system has focused a lot on wellness and burnout and trying to avoid that, which we know is a national problem. Yeah, I will know when I'm burnt out and ready to retire when I can't treat that patient and family, that mother, that caregiver as a new experience, meaning that, boy, and you guys know this, you've had 10 patients you've talked to already about bronchiolitis, and then you have that 11th patient. That mother's never heard about bronchiolitis, has never heard about RSV. I owe it to that mother, I owe it to that child to make it be fresh and exciting. And this is new for her. I can't say, oh, Mom, like, I've already explained this 10 times. She's never heard you say it. So she deserves that mother, that caregiver, that parent, that child deserves your best, even though you're exhausted, but they deserve your best. And when I can't do that, or when I feel like I just mail it in, okay, then I'm going to have to retire.
So yeah, the Buddhists talk about that. They say the child's mind.
Mhm.
And the child's mind is curious and not afraid of failure. That's why children learn.
Mm.
As adults, we become fossilized. I don't want to mess too much with my computer before we get the Zoom call. Because if I press the wrong button and the thing stops working, there's no time to go run to Apple Store to get it fixed. The child has no qualms. They just press the buttons to see what happens. And they learn, if I press this button, this cartoon comes up. That's what I like. But that's a beautiful thing that open-mindedness and lack of fear of failure. That's how you learn.
Absolutely.
So beautiful. And why did you become a hospitalist as opposed to being an officist or a subspecialist?
Yeah. And I have to say, I have nothing but respect for our outpatient colleagues and the challenges that they face. And in my role, I oversee our outpatient offices with pediatricians. I don't know how they do it because they have just so many demands in their time and well children and sick children and having to determine when that child is too sick to follow up with me tomorrow and or needs to be sent to the hospital. I think that's very, very hard. Now, of course, in residency, you're guided by your mentors. And I had some wonderful mentors who were pediatric hospitalists. So that certainly helped me. But I thought these hospitalists are the most arrogant people I know. And I want to be part of that. When I say arrogant, they would do a little bit of endocrinology. They would do a little bit of pulmonology, a little bit of GI, a little bit of infectious disease, a little bit of nephrology, a little bit of everything. They weren't a subspecialist but they felt like they could do those things without involving specialists. And that was very appealing to me, especially someone who really has a lot of interests like that. And so when I think about that, for example, if I have a child who's in diabetic ketoacidosis, sure, I'll call an endocrinologist to talk about what the long-term management and getting that child their care, but I can manage DKA. I don't need to have an endocrinologist help me manage DKA. Asthma, sure. You should see a pulmonologist if you have severe asthma and you're thinking about monoclonal antibodies, whatever the newest therapies are, sure. But I can manage asthma. I can manage most infectious diseases. Now, if you've been spelunking in a cave in Ohio, okay, yeah, let me get infectious disease because that's a weird exposure there. But do I need infectious disease for community-acquired pneumonia? No, I should be able to handle that. And so I really enjoyed that they felt like they could be part of everything. And I think for me personally, it has allowed me more time to spend with parents and caregivers, with the patients. I can make multiple visits with that patient. I think about how the challenge it is when I did outpatient to bring people at the stages of change model. I think about children with asthma and the parent smokes. I would talk about it in the office. I'd be limited with my time because I'd have other patients coming behind them. But in the hospital, I'll give you an example. I'll see that patient in the emergency room and I'll say, okay, mom, we have to admit Johnny because he has a severe asthma attack and we're going to give him the best care upstairs. One of the triggers for asthma can be cigarette smoking. I know you smoke. We'll talk about that later, but I just wanted to let you, maybe we can help you find a better way. Okay. You just plant the seed there. Well, now they get admitted. Come in, talk to the mother and say, Mom, I know we talked a little bit just about smoking and that can be one of the triggers for Johnny. And I know you want what's best for Johnny. Here's some information you might want to look at. And we'll talk a little bit later. Maybe a couple hours later, it's like, I don't know if you had a chance to read those things, but really, I want to help Johnny really be the best he can be. And every time he's at the hospital, he can't be in school. And I know how much you love him to learn. And maybe we can talk about how to help you quit here, Mom. Come back a few hours later, right? And you can have that conversation. And so you can really bring people along where, boy, what a challenge that is in the outpatient setting, I think. I think for me, though, I do want to mention two things. So one is I am board certified in pediatric hospital medicine, but I'm a pediatrician. Right? And so when I have you in the hospital, I am always thinking from a general pediatrician standpoint. And I think about how I can help my colleagues in the outpatient setting. For example, with asthma, I know I have some friends at other institutions and they won't start a child on a controller medication. They'll say, okay, that's the primary care's job to start a child on a controller medication for asthma. And I think that's complete nonsense. Right? I have you in the hospital. I can spend the time to talk about why I think your child needs a controller, what a controller is, all these things, so that when they go to the outpatient pediatrician like you guys, then they already know something about it, because you don't have 20 minutes to talk to them about what a controller is. But maybe you can say, oh, I see your doctor in the hospital started, you want a controller. How is that going? And the parent has some knowledge about that. I'll say all the time in the world in the hospital to have that conversation. And if that's going to help you guys out, I want to do that. So I always think about that. How are we helping our outpatient colleagues? The last thing I'd say is, as a physician leader, it has been very helpful to be a pediatric hospitalist, because you really start to understand things from a systems perspective. So in the hospital, you're interacting. I'm right in the center of everything. So I'm interacting with PICUs. I'm interacting with our EDs. I'm interacting with our outpatient colleagues. I'm interacting with our subspecialists. All of those together, respiratory therapy, radiology, whatever it might be, you're right in the middle of everything. And that helps you view things from a system perspective, that as a leader, I think you start to understand how things operate. You think about efficiencies, you think about scale, you think about all those things, that it just gives you a very unique vantage point. So I've appreciated that.
I guess you learned all that stuff when you did your CPE.
I did, yeah. I think that when becoming a certified physician executive was in part based on the experience through my MBA, but then also just my experience as leadership, which happened right out of residency. And so I was able to be put in a position for overseeing a pediatric hospitalist group, and then ultimately the director of pediatrics for that system, which was a kind of medium-sized, smaller system, before then moving to WellSpan Health in York. So I think that definitely gives me perspective. It's very helpful. And I was really happy through the American Association for Physician Leadership, to get my CPE by meeting folks. Many of them, almost all of them, were not pediatricians, understanding how adult hospitalists work, how adult specialists work, and how they blend that into leadership.
Do you think that's a useful thing for a pediatrician or a medical doctor? At what stage in
I
their
think
life?
so.
Go for the straight.
Yeah. Yeah, I think it's helpful, George, for those folks who see themselves as wanting to have maybe a greater span of control within their organization, overseeing a lot of things. So much of my job, non-clinically, is managing people, and trying to make sure people are upholding the highest standards of professionalism within our organization. But then also thinking about how to bring about new initiatives within the organization, whether it be, I've been heavily involved in bringing universal lead testing to all of our outpatient practices. And so at 9 to 11 months, which is part of Eat Bright Futures within Pennsylvania, but also at 2 years as well, because we realized that we lived in an area that was very endemic with high lead levels. Having that business background, having that credential, I think helped me look at things from a system perspective, look at who our stakeholders were, both within the organization, external to the organization, and with the support of our leadership at WellSpan, was able to really have achieved success with a huge increase in the number of children who were actually getting their lead tested. We brought point of care lead testing to our offices. So a dry blood spot, meaning while the child is there at the visit, Mom, I see your child is due for their lead. They're 9 months old. Let's get that done here in the office. Because if I send you to the lab, boy, it's all you can do to get your child to the appointment. And if I can say, here, let's do it here, the number of children who are now compliant has arisen exponentially.
Yeah, I get the question, is an MBA better than a CPE? Which one should I do? Personally, because I did both. I did the CPE first, then I did the MBA. The good part about the CPE is you learn all those things: leadership, strategy, scale, how to deal with doctors and so forth. There's a lot of CME in that, because you got to get CME anyway. It's all online because it's interactive. Remember those 4 leadership courses: the accounting, the leadership, the strategy. I forget the other one, finance. Big ones. Yeah. You do it online, interactive discussion forums. That's very good. And then if you want to go further and do the MBA, you take all those credits, you roll it up, and then you get a formal MBA.
Yeah. I found the MBA has been very helpful, because I did a general MBA through at the University of Massachusetts with a little bit of a help. Yeah, with a little bit of a healthcare focus. Yeah. And so I appreciated that my colleagues there were some physicians, of course, but a lot of them were non-physicians. And so I got to learn about their industries. It wasn't just case studies on hospitals or healthcare systems. It was non-healthcare, Fortune 500 companies and things like that. And my background when I was in college, I mentioned at the beginning, that's when I made the decision I wanted to go to medical school, but I didn't want to go right away. I wanted to get some experience in the business world first. And so I did consulting for several years, and particularly market research consulting. And I found that was a fantastic, phenomenal experience to train me for what I would do in the future, not just from a leadership standpoint, but also from a clinical standpoint. When I did marketing, a lot of it was trying to understand the consumer and understand the role that a product might play in that consumer's life and try to sell them on that, right? So a company would come to us and we would try to decide what the way we would study the consumer would be. And then I would be in charge of interpreting the data and then coming up with recommendations for the client. And made me start to think. We had one client, Coca-Cola. When we looked at consumers in two different locations, two different countries, and we asked people to think about their experience with Coca-Cola and to bring in pictures that would speak to them about their experience of drinking Coca-Cola. And this was out of Harvard Business School, patented technique by Jerry Olson there and Jerry Zaltman. And it was amazing, guys, what these consumers would bring in. One group of consumers would bring in pictures of rebels and motorcycles and tattoos, chains and things like that. And then you'd ask them why they brought those things in. And as you layer down with the technique, kind of psychologically trying to understand, they would say, I wasn't allowed Coca-Cola as a kid. So I used to sneak to my friend's house and I would drink Coca-Cola. So now when I drink Coca-Cola as an adult, I feel like I'm a rebel again. There was a whole other set of consumers who would bring in pictures of birthday cakes and birthday parties and things like that. And then they would say, that group, I remember Coca-Cola was for special occasions. I remember my birthday, we would have Coca-Cola. And so now when I drink Coca-Cola, it's like a little bit of a surprise and a little bit of a celebration for me. And so what I would do is I would take that information, and you could see how that might be in an advertisement where you might just have a can of Coca-Cola and in the background, just a firework. And for that consumer, just that mental image that you have of what Coca-Cola means for you would resonate. And so I thought, and I've seen how that is so integral to what I am as a pediatrician. Clinically, sure, the child comes in with a broken leg. We're going to have orthopedics fix that. Great. But if I don't understand the context from where that child is coming from, if I don't understand what role that broken leg plays in that child's life, he's a basketball player. He's the best person on his team. He's not going to be able to play basketball this season. He's worried about if he's going to get a college scholarship. He's worried if he's ever going to play again. Yeah, the leg, fine, sure, absolutely. But I need to address that. I need to address that anxiety. I need to understand the context where that comes. I mentioned the example of stopping smoking. It drives me crazy when, people are saying, just tell mom smoking's bad. Who doesn't know? Who doesn't know that smoking is bad for you? If I don't understand the role that cigarettes plays in that mother's life, time of helps her de-stress, maybe it's soothing or it's a comfort or reminds her of her parents, whatever it is. If I just say stop smoking, that's not going to work. I have to understand the role that smoking plays in that mother's life and then try to think about alternatives that might give maybe that same satisfaction or pleasure, all the while focusing on their child and saying this is best for their health. For me, marketing was so vital. And I think, again, both clinically from a leadership standpoint, what am I doing as part of a clinical team? I'm trying to sell the nurses on this is the best plan for this child. Sell the parent saying, this is the action. I think your child needs this antibiotic. or I think your child can go home, whatever it might be. That's marketing. That's trying to figure out how to make that attract.
That's not marketing. So, I got a question for you. So the old College of Physician Executives, that is changed into this conference you're going to go to. The names change, right?
It's APL now. American Association of Physician Leaders.
Physician leaders.
College of Physician Executive.
I don't know why they changed the name, but they did change the name. I found that the most rewarding thing of that was not to do it online, but to do it in-person meetings, because the stories people told you and the leaders that were there, it was just phenomenal. I always felt embarrassed. I had imposter syndrome. I had a family practice guy from Indiana, I think, or Ohio. The guy had a skiing accident. He had 2 wine stores that his son ran. He had his own family practice that he was a Work Without Walls, that he worked 3 days a week. And then they had already 200 physicians and he was in leadership. So he spent 2 days a week in the office doing administrative stuff for the group. And he said to me, I'm going to give you, he was a little older than me, not much, maybe 5-10 years older than me. He said, Herb, I'm going to give you some advice because you're going to burn out. I'm like, I don't do half of what you do. He goes, whenever I come to these things, I come in a day early. And I go to the spa, I relax, I get a good dinner. You need to take care of yourself. You don't come in the day of the meeting and leave right after it. You need to take care of yourself. That's how you build resiliency. And I think that hallway conversation, and it was funny because I said, oh yeah, I did book an hour massage, and it was really funny. I didn't know we booked at the same time. We bumped into each other as we were going in for the massage. But I think that was that was so valuable, those conversations. I dropped out of it because as medicine in the US changed, it became very focused on large systems. And I'm not interested in large systems. I'm interested in small independent practices. And the amount of education they used to have, they had a boot camp that was 2 days for running practices. Everything from insurance to accounting to billing, everything. They did away with that because it's more about systems. But to your point about marketing and sales, I always say this, everything we do in life is a sale. You ask a woman out on a date, you're selling her on the concept that you're a suitable person to get married to.
You're safe. Yeah.
Yep. And whatever her things are that she's looking for in a long-term relationship, you're selling her that you can give that. She's selling you that she can give you whatever you want in a romantic partner, whatever that is. But marketing, which was very difficult for me because I am an outcomes-driven person, marketing has no outcomes. Marketing is about getting eyeballs to look at you, touching, building brand awareness. And that's very hard to measure, but the marketing informs the consumer, and then the sales team comes in and closes. But marketing to me is very difficult because measuring the outcomes, when I had the urgent care that say, I would spend $10,000 sending postcards, that's how old I am, to the parents' house. And then they would be like, you have to send them, first of all, you have to send them beginning of winter 3 times, so the first 2 get thrown away. Nobody pays any attention to them. When you touch them the 3rd time, they're like, oh, this might be interesting. I'm going to put this in the refrigerator with the magnet because it gets sick in the winter. That's one marketing. The other thing that they taught me is each urgent care, of course, suffers in the summer because we don't do it well. We're not supposed to do well child exams. And if you're honest, you're not doing the sports physicals. So the volume totally drops. That's when you market. But that's so hard because your revenues slow down. But that is the time where you want to build that brand awareness. Like, we're here if you need us. Don't forget about it. But that's a very interesting lesson. I want to ask you quickly, what was it your experience to move to Lynchburg from Boston?
Yeah, it was
A small town.
Yeah. So in 3rd year of residency, I was in Philadelphia. I was Boston for college at Harvard and medical school at Tufts. And then St. Christopher's Hospital in Philadelphia for residency, I had two options. One was to go to Johns Hopkins All Children's Hospital in St. Petersburg, Florida, a fantastic institution. And I don't know if you've ever been to St. Petersburg. It is absolutely gorgeous. I went into a hospital and there were these sailboats on the bay. And this is amazing. And it was to be the associate program director, a residency director. And then the other option was to go to Lynchburg, Virginia, and head up their hospitalist program, pediatric hospitalist program. And I couldn't pick Lynchburg out on a map. I knew Lynchburg, Tennessee, just from Jack Daniels or just from the bottles and things like that. But I didn't know Lynchburg. But it was really a fork in the road for me. And I'll say, I had always thought, again, parents being teachers, I would stay in academics, pure academics, proper academics. At St. Petersburg and Johns Hopkins, of course, is a fantastic opportunity. But the opportunity to build something, to be the leader, was very attractive. So that's why I had chosen Lynchburg. But it was a little bit of a culture shock, absolutely. Hearing that I was a Yankee, I was like, first of all, I'm a Red Sox fan, so I'm not a Yankee. So that was an insult right there. But really made some great friendships. I think one of the big things that was interesting for me to learn about was rural poverty. So I was used to urban poverty in Boston and Philadelphia, but rural poverty where there was a real lack of resources available. So I was used to a city where I could say, okay, there's the food bank over here, or there's the library over here. It's walking distance. There's a robust transit system. You can get around and things like that. Lots of activities going on. In a rural setting, that really doesn't exist. So people who are struggling with gas money and telling them, okay, you have to travel 10 miles to get to the library, as opposed to a city where the library is just a short bus ride away or even within walking distance, perhaps. That was very interesting for me to learn. I'd never seen a trailer park, for example. Certainly the culture down there, particularly with hunting and using weapons and things like that, that was new. Coming from Boston and Philadelphia, that was a big adjustment. But we just have some wonderful friends there, made great friendships, a lot of dedicated people there. I miss some of those friendships.
It's a beautiful part of Virginia. It is beautiful. It is beautiful, but it is very isolating if that's not where you grew up. Because you start missing, I'm sure Lynchburg has a Walmart, but there are many communities in that part of Virginia where there is no movie theater, there is no Walmart, there's no Target. Maybe there's a Chinese restaurant and that's it. And if you want to go buy underwear, you got to drive on the interstate on 81 for an hour to get to Lynchburg or Roanoke, to get to a Walmart to buy your underwear, because these little towns don't have that. They don't have the amount of people necessary to sustain a store that size. And when you've always been in big cities, you take it for granted. I never go to these stores. I hate shopping, but I do. But eventually you got to buy a t-shirt or you got to buy socks because, they got holes in them. I would imagine that's the lesson now with Amazon delivering them. But that was my experience. Did they make you eat a squirrel stew?
No.
Oh, thank God.
Yeah, it was interesting because I remember one of my nurses, she was terrific nurse. And she says, Dr. Russo, I got to show you my son. Look at what he did. Then she pulls up a picture on her phone of her son proudly standing with a rifle and 40 squirrels that he'd killed arrayed around him. And I'd never seen anything like that in my life. And I said, congratulations. Looks like he's a great shot. I was like, oh, that's interesting.
Oh, in your health system, around your health system, are there any private practices, independent Pete's practices, or they're all owned by the system now?
No, there's just a few. So at WellSpan Health, we're a large integrated healthcare system. We're in several counties. I think the last time I checked was 9 counties where we draw patients from within South Central Pennsylvania, even going up as far now as Danville, which is right near Geisinger. And so there are some federally qualified health centers and a few private practices, but not very many. The challenge that I find is that, so I oversee pediatrics in all of our settings. So our NICUs, our inpatient units, our outpatient units, urgent cares, emergency departments. A lot of the care, about a third of the care for children within our system, is delivered by family medicine doctors. And so it's been a learning adjustment. I'm not a family medicine doctor. And certainly as a pediatrician, we approach things maybe from a little bit different perspective because of just only seeing children. So things like immunizations, for example. And it seems to be too that there are parents and caregivers who self-select towards family medicine doctors versus pediatricians. And one of the things that I work very hard on is trying to make sure children get the same level and standard of care, whether you're a family medicine doctor or a pediatrician. And we have wonderful family medicine colleagues. I do. Sometimes it is funny, though, when you don't see a lot of children as a family medicine doctor, and they'll say, your child has sickle cell disease. I think they need to see a pediatrician. Right? And as a pediatrician, you would say, okay, he has sickle cell. Okay, he has Down syndrome. Okay, yes, there's things you have to do with Down syndrome, of course, surveillance, all those things. But okay, yeah, he has Down syndrome. Okay, doesn't necessarily make them super complicated. Sickle cell disease, and certainly as a hematologist is going to be helping to manage that, but I can do that primary care. That's been a little bit of an interesting thing. And one of the things that I have been able to do, I did in Virginia, and I've done it to an extent here at WellSpan, is to co-locate pediatricians and family medicine providers in the same office. The idea being, and this is not, I didn't create this, I want to take credit for it, other systems do this. What I really have found is that rising tide lifts all boats, that we have families coming in because there's a pediatrician now. And again, some families prefer to see a pediatrician rather than a family medicine doctor. But the pediatrician can't possibly see all those children. So the family medicine doctors then start to see some of those children. And if the family medicine doctor has a child they have a question about, they'll just run over and talk to the pediatrician. Hey, can you come take a look at this rash? What do you think about that? So it raises everyone's game. And so I really have found that a fantastic model.
Yeah, talking about how to work. Somebody asked me if I want to be a family practitioner, and I'm like, are you nuts? How do you know? How do you know all those diseases? And you treat their grandmother, and then in the afternoon you treat the grandchild. I don't know how they do it. It's just, and they do it well. And I can't do it. It's just too much.
I mean, it's hard enough dealing with the families and they're not our patients. To think I would have to deal with the family as a patient. Oh my gosh.
Yeah. Oh, not only that, the pathology is different, and the approach to the disease. Like, as pediatricians, I say this all the time. Like, we agonize as to whether or not starting a statin in somebody with a cholesterol 170 at 15. If your family practice is 170, why would you wait? What do you want? Lipitor or Crestor? I'll see you in a month. We'll redraw your labs. Right? And it's just like, I don't know. There's still a developing body. And how long are they going to be in Lipitor? And maybe Lipitor's safe for 20 years in an adult liver, but for 40 years, starting when you're a child, is that safe? Are there any outcomes that say that if I start this child at 15, their cardiovascular risk is less than if I wait till they're 30? So our thinking is very different.
Yeah.
But they do a wonderful job. Thank God they're out there. So I was going to ask you, and this is how we met in Detroit, what attracted you to screening early with autoantibodies to prevent decay from a system-wide in a community hospital? Because you don't have an endocrinologist, you don't have a PICU in your system. No. So what attracted you to that field?
Yeah. And I will say our inpatient pediatric unit at our largest hospital, we function, and that's where I practice most of the time, we function as like a sub-PICU intermediate level unit in terms of the care that we do, insulin drips, continuous albuterol, high flow nasal cannula, those types of things. But as a pediatric hospitalist, I know firsthand the devastation for diabetic ketoacidosis in a child. Just last week, I was sharing tears with a mother of a 10-year-old boy who was newly diagnosed with diabetes, type 1 diabetes. It's hard. It's overwhelming. And these children are very sick when they first come in because a lot of times the parents don't recognize the symptoms. Oh, he just has a stomach bug. That's why he's vomiting. Well, the sugar's 900. His blood glucose is 900. That's why he's vomiting. Oh, yeah, he drinks a little bit more. I just see he wet his bed every now and then. I figured it was behavioral. No, these children come in very sick. And so I think about how when you have that new diagnosis, as a pediatric hospitalist, I see how overwhelming it can be. And the information is just a flood. And even though I tell the parent, I said, your child is going to be able to do the things he wants to do. It's just going to be different. We're going to have to talk about ways he eats and things like that, but he's going to be able to do the activities. I tell them about the patient I have who's a Division I college basketball player who has type 1 diabetes, who the biggest struggle for him is the opposing players try to rip off his meter, his CGM, because they know if they do that, then he has to go sit out and have the trainer tape it up again. But I think about how with early screening, we can, to a large degree, prevent that child from coming to the hospital in DKA if we know that child will develop or has a high likelihood of developing type 1 diabetes in their future. We can start that preparation. I would much rather have a controlled setting before your child is sick to talk to you about the dangers of DKA, to talk to you about here's what we're going to do, here are the signs to watch for, to allow that to permeate, to really take advantage of all the resources that are available online to help you get to know your disease, as opposed to waiting till the child has this and then it gets dropped like a bomb on that family. So for me, it's a very personal thing that I really want them to be able to understand the disease and the progression, and screening is going to help us to be able to do that. So what we are looking at, and I think in the next 6 months, we'll be able to have screening at a targeted level, so targeted towards families where a child has been diagnosed with type 1 diabetes, screening other family members, but also adults who have type 1 diabetes, screening their children, eventually doing other autoimmune diseases, screening the children of those family members who have that. And ultimately, I'd like to see us offer it as a universal screen for all children, meaning we would tell parents, we have this ability to detect whether your child might develop type 1 diabetes with a fair degree of certainty, and we're going to offer this for you. Now, some parents may choose, they don't want to know. That's understandable. But for those who do, I really feel that knowledge is power. But ultimately, knowing that there are treatments available now that can help delay the progression. There's a treatment available that can delay the progression of type 1 to type 1 diabetes. Can't prevent it, but can delay the progression. Boy, as a pediatric hospitalist who sees these children when they're super sick, and again, the tears of those families, if I can prevent that, I'm all on board for that. Well,
Yeah. And what do you do once you stabilize them? Who manages? Is there a pediatrician in the community that has an interest in diabetes and sees all the diabetics, or do they have to travel to see a peds diabetologist?
yeah, there's so few pediatric endocrinologists there's actually none in our area except at the Academic Medical Center, which is either Hershey Medical Center, which is about 45 to 50 minutes to our north, or Johns Hopkins, which is about maybe 50, 55 minutes to our south. And so what we do is we stabilize a child, get them out of DKA, send them home on a plan, usually that we've talked with an endocrinologist about, for how much their long acting should be, carb counting, glucose targets, and drop factors. That we have a plan, and then they follow up as an outpatient, typically with a pediatric endocrinologist at one of those academic medical centers, who will then use all their resources for diabetic education, helping the family get the supplies that they need, anything like that. So it's really a partnership, but we will discharge them here as an to then follow up as an outpatient rather than transfer them, really, because it's really unnecessary, right? DKA is actually, I think it's one of the more, it's a very bad diagnosis for the child from a academic standpoint. It's actually very fascinating to think about the pathophysiology of the disease and how you would manage it. And so I love teaching about it. This is what's happening with the pancreas. This is why we're doing this. These are why we're sending these antibodies, all those things. I like that part.
But it's a very dangerous disease.
Absolutely.
I was looking at some of the stuff. It's hard to tell, but somewhere between 0.3% to 1% of children in DKA die. Depends on who you read. 0.3% is 3 deaths per 1,000. Measles deaths are 1 per 1,000. So this disease kills children 3 times faster than measles does. when I did it with a calculator and I wrapped my head around that. That's why you have PTSD. You're treating these kids when you're a resident. The fear is real.
Yes.
The danger is real. And I'm just talking about the worst of all possible outcomes. We're not talking about all the other damage that gets done, even if they walk out of your hospital. So
That's so true.
it is a scary disease. It really is a scary disease.
And I think
Could make it
when I
less
see,
scary and go away.
Yeah.
Man, what a win for society.
oh, gosh. And I think about sometimes how, because we have children who come in again and again, non-compliant. And I think about, could part of that have been averted if we were able to do good education prior to the diagnosis? If we were able
Yes.
to get them acclimated to what it is like? Because again, when you get that new diagnosis, it's like drinking from a fire hose, to use that expression. And so if we were able to have a better education, because it was not that stress of the hospiitalization,
No, it
I think we
can.
get better compliance.
Can. The FRIDA study has shown that one of the biggest one of the risk factors for multiple episodes of DKA is having presented in DKA. So if you can prevent 95% of DKA at presentation, you're going to have a downstream win that these kids are not. And what the researchers say and what they know and what they feel is that the more beta pancreatic cells you preserve, the less pathological loads, the less insulin requirement you have, the better glycemic control you have, and the episodes of DKA stunt the pancreas to the point where it doesn't produce any endogenous insulin, and that in itself puts you at risk for all these other things to be abnormal. But so the science is beyond fascinating. Yeah, you could read, and these studies have lasted years, not 2 years, but 10, 20 years. And they have 180,000 patients that they've been following. And you're like, my goodness, who has the patience to follow 180,000 patients for 10 years? But it's amazing. The science is amazing. The disease is scary, and we could get rid of this disease. Man, that and breast cancer, what a win for the humanity.
Oh, gosh. Yes.
So I have one last question because I want to be respectful of your time. You've been very generous. What is your favorite management book and why?
I think there's one that jumps to bat. And we talked a little bit about vocation before, but Servant Leadership by Robert Greenleaf is always one that I try to read every few years. And that really talks about finding your calling and where the world's deepest need meets your deepest desire. But a book that I feel has affected me profoundly is called Thinking in Bets by Annie Duke. Now, Annie Duke is a professional poker player, one of the first female professional poker players. And she wrote this great book that I really apply to clinical medicine a lot. As a poker player, and she talks about her experiences, she talks about how she approaches things. She then uses that as it's called decision science. And so I'll give you an example. So one of the things that affected me profoundly was uncoupling decisions and outcomes. So, for example, she talks about how she would go to meetings and leaders and she would say, what was your worst decision that you made? And they'd say, I hired this CFO and then he ended up stealing from the company. And she said, that was a bad outcome, but was it a bad decision? Now, it could have been, right? You could have said, I'm going to hire this CFO. I'm not going to check his references. I'm not going to really interview him or things like that. Yeah. But if you did that, if you did thorough interviews, you maybe had the person shadow, maybe you followed all the references, all those things, the outcome is separate from the decision. And so in poker, you focus on the best decision based on the knowledge you have available with the cards and the players and everything like that. You can't control the outcome. You can't control what cards get turned over, and you might lose some hands. So the best thing for you to do is to focus on the decision. And that's what I talk about when I teach about medicine, I can't control the outcome. But how can I make the best decision possible for this child? Using vital signs, labs, my physical exam, the history taking, everything to make the best possible decision. I can't control whether the child gets better or not. I can't control whether the parent gives the medication or not, right? There's going to be treatment failures that happen. There are going to be weird things that you miss, right? Like, can I focus on making the best decision possible? I think the other thing that was very helpful, she talks about putting the odds in your favor, right? And that's what you do as a poker player, right? Again, you can't control the outcome, but how can you put the odds as much in your favor as possible to give yourself the best chance of winning? That's what I talk about for clinical medicine. I want to put the odds as much in my favor as possible. So that could be getting a lab. That could be getting an x-ray, could be getting a study of some sort, thinking, getting the physical exam, getting the history, all those types of things. The more information I get, that knowledge then helps me put the odds in my favor. For example, I will tell residents, and I will tell parents even too, I can't tell you what your child has, but I can tell you what they don't have, right? So you know this, right? So parents think their child has cancer, and I'll say, I can tell you, we've looked at a CBC, we've looked at the smear, just the history of what you're talking about. Cancer is very unlikely in this situation. I suspect your child has a virus, viral suppression, whatever it might be. That's the white count's a little bit low, whatever it might be, but it's a lymphocytic predominance. Okay. I can't prove it's a virus. I could do a nose swab and maybe it's positive, maybe it's not for something, but there's a million viruses a child can have. But by putting the odds in my favor, I can rule out the scary stuff or the bad stuff. I can reason with the parent and say, we talked earlier about tempo of the illness and say, if your child had a bacterial infection for the last 5 days, I would expect them to get worse and worse until some doctor had the bright idea, hey, maybe we should start antibiotics, because that's the natural course of the disease, right? The natural course is the bacterial infection is going to get worse and worse and worse until someone treats it, and then with the appropriate antibiotic, it then resolves the infection. The fact that your child hasn't gotten worse over those last 5 days makes me more reassured. The fact that you haven't seen a sudden worsening. They're not hypoxemic anymore, or never were hypoxemic. They're not hypoxemic, whatever it might be, well appearing, things like that. The more data points I have, the better I'm putting those odds in my favor. So I think about that a lot as a pediatric hospitalist, where I'll talk about admitting patients where I'll say, you're going to come away from your rotation with Dr. Russo and you're going to say, he's the laziest doctor I've ever seen. He doesn't like to do lab tests. That's true. He doesn't like to do x-rays. Guilty. He doesn't like to give medicines. Absolutely. If I don't have to give him medicine, I'd love to not give him medicine. He doesn't like to place IVs. I'd much rather the child take it by mouth than IV. I can watch you. I can come back on multiple occasions and watch you. And the more I see of you, the more I'm putting those odds in my favor to say, you know what? I've watched you for 12 hours, 18 hours, 24 hours, 36 hours, whatever. I've gotten to know you over this time. I feel more comfortable in my diagnosis because now I've put those odds in my favor by having you come in and let me watch you.
Wow, that's beautifully said. I'll have to read that book. Thinking of that, I'll have to read that book. As you recount all of this, of course, I'm all outcome driven and avoid bad outcomes. And the reality of it is, it doesn't matter how much you do, how good you are. Sometimes you're going to make the wrong decision. You're going to have a bad outcome. And that's just part of what we signed up for. And I think that's one of the most difficult things about medicine. You might make the right decision, the outcome's still terrible. Or you might make the wrong decision and the outcome's terrible. And it's just part of being human. But it's very tough. Yes. It's very tough. Thank you so much.
I think you can make a bad decision and have a good outcome. So the example that they give is, I can walk out in the middle of the street in busy traffic and make it to the other side. There's a good outcome, very bad decision.
Oh, I'll give you one in our field. You can go to the urgent cares around Northern Virginia, get swabbed for a $1,200 respiratory panel, come out with RSV and a CPAC because you have an ear infection and no fever. Totally poor decision making. Who cares if you're RSV positive when you're over 2 years of age and you're not going to go to a hospital?
Yeah.
Who cares? Oh, the mother wanted to know. Oh, I said, who cares? Why'd you do it? Why'd you give him the CPAC?
Ear infection.
And the child gets better, and the child was going to get better regardless of what you did.
Yeah.
You're focused on that outcome and saying, he got better because of what I did. When in fact, if you focus on the right decision, that is just so crucial.
Yeah. Well, it's been a great time. Hope to see you
Thank you.
again soon. Very
Yes.
interesting conversation. Thank you for your time.
Thank you both. I really appreciated this.
Thank you for listening. This has been a production of the Pediatric Lounge. On the show notes, you will find links to our co-host and other important notes, as well as a timetable of the topics discussed today. Don't forget to follow us on social media and subscribe to wherever you listen to your podcast. Leave us a great review, as it helps us greatly. In the meantime, we will see you next week. The Pediatric Lounge. The conversations are not intended as medical advice, and the opinions expressed are solely those of the host and the guest.